The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD Warriors. I am Tony Urbanek, and we are gathered here today for the next episode of TMD Demystified. Today, the topic and title is Building a TMD Practice. Building a TMD practice. Now, make some assumptions. I assume that if you're watching this, you would either like to build a TMD practice or have some experience treating TMD and want to increase your visibility or the number of patients you have, or that you are just investigating this and find it an interesting opportunity to add a service to your current practice and build a TMD practice within your current dental practice, or your current oral and maxillofacial surgery practice, or your current orthodontic practice. And we are going to discuss all of those avenues and then some as it applies to building a practice while solving the TMD problem. It isn't that hard. I literally fell into the situation of developing a non-surgical TMD practice of great magnitude. We'll talk about that a little bit. I'm not here to be braggadocious and how many patients we see, but it's higher than I have ever heard anywhere else. I can talk about how we did that. I can talk about why we did that. I can talk about the patient's experience, the doctor's experience, the referral doctor's experience. But what I've kind of determined over the past few episodes, that the episodes that are more often watched, viewed, are episodes that apply more practical knowledge or go in a more practical manner than theoretical or highly technical. If you've watched enough of these episodes, you know my opinion is that TMD is not a complicated issue. There's a lot of people who want to make this complicated for various reasons. I have my opinion on why they want to make it complicated, but they definitely make it complicated. My motion and work in TMD is to try to decomplicate it, demystify it, make it as simple as possible to understand, make it as simple as possible to treat your patients for their benefit and your benefit as the practice provider. I always like to speak with things that people can view. I'll do a little bit of that today, but really want to talk about is how do you build a TMD practice? And this can be a practice, a standalone practice, like our current practice is. My practice with my associate, Dr. Urbina, and myself, Dr. Urbanek. We have a very, very large non-surgical temporomandibular joint practice in Middle Tennessee that has been transferred from originally an oral and maxillofacial surgery practice. And as I'm sure you must be aware after viewing any number of episodes, I am an oral and maxillofacial surgeon who no longer practices surgery. And I did surgery on the temporomandibular joint for 30 years and over 2,000 cases. Now, our practice is totally devoted to non-surgical care, and it's a lot more fun, frankly, although I did enjoy surgery thoroughly, but it's a lot more fun because our patients are having a lot more fun. We're getting much, much better results non-surgically, and it's much easier to do. So if you're interested in helping people, really helping them, because we get constantly, and you've heard me talk about this before, but it's a constant line of patients who come through here and they've been misdiagnosed, mistreated for most people for years. We get kind of, de novo patients, virgin patients who have not seen anybody before, and they have these symptoms, and they come through us from a referral from a dentist or a PCP or an ENT doctor. That is the rarity. The vast majority of our patients have seen multiple doctors over multiple years. I mean, average probably 10 to 15 years to 20 years average. Patients coming through here that have seen multiple doctors who have listened to their symptoms, made or not made a diagnosis of various kinds, but obviously did not fix the problem because they were finally referred in here to see if it was their temporomandibular joint as the cause of their issues, and in almost all cases it was. So we have a very, very large standalone non-surgical practice devoted only to temporomandibular joint, and I would recommend that for anyone who wanted to have that kind of practice and lifestyle without the stresses of a general dental practice, without the stresses of a active oral and maxillofacial surgery practice, whether it be an office practice or a wide scope maxillofacial practice like I practiced for 46 years. The broadest, largest scope of maxillofacial surgery is what I did until I finally, called it quits doing surgery. But you can build this practice pretty simply, and I'm going to explain how you do that and why you do that, and then I'll leave it open for comments and questions later on. So my story, I'm not going to repeat it again, but I found that surgery was not the answer because of my research experience and broad background in research, all the way up to having my own research grant through the NIH for 2 years while I was in my early stages of training at Vanderbilt. I was not afraid of doing research, and I took upon myself the challenge to see if I could figure out what nobody else could figure out about this problem, because I knew that nobody else did. And we figured it out. It's quite simple. And if you apply those measures and understanding of what's going on within temporomandibular joint, you can have just continued success. And it's not hard once you have continued success with the patients to build a great number of patients. Now, the number of people who have temporomandibular joint symptoms can be debated. The statistics within the literature vary anywhere between 15%, or roughly now, 15% and 30%, 35%, maybe the highest, almost exclusively females. It's not 2 to 1 female male. It's like 8 to 1, 9 to 1 female male. It is a female problem primarily because estrogen exacerbates inflammation. Estrogen makes inflammation worse. And the whole understanding of temporomandibular joint problems is built upon inflammation, with understanding inflammation within the temporomandibular joint and what happens after the joint becomes inflamed. Again, covered in many different episodes in many different ways, but we're talking about how do you build a practice now on this. First of all, you have to know the technology. You have to take the course. We have an online course teaches you exactly why inflammation within the temporomandibular joint can create all of the symptoms. Anatomically, physiologically, in the literature, discussed facts that can, once understood and read, will be very clear that inflammation will cause frequent or recurring headaches, earaches, jaw pain, neck pain, tinnitus, fullness in the ear, subjective hearing loss, vertigo, dizziness, upper shoulder and upper back arm pain, and arm, hand, finger tingling and numbness and various kinds of locking. But roughly, I quote my own quote and my own experience that roughly 45% of females have one or more of those symptoms associated with temporomandibular joint. It is extremely common. I come to that conclusion many different ways. I think I mentioned in an episode earlier that for about 9 months, I did 41 lunch and learns to primarily general dental offices, and visited an office that had an office staff almost exclusively females, anywhere between 5 females and 25 females. And I always ask the question of my audience, after I went through that symptom list that I just did for you, what percentage of you, or actually I would say how many of you, raise your hand if you have one or more of those symptoms currently. And at least half the room's hands went up. Now, that's pretty, rough and dirty estimate, but it's a fact. It happened pretty much 41 times out of 41 times. Half the hands went up when I said, how many of you have one or more of these symptoms going on currently? The other method I use to determine how frequently this is, because in my travels, in my lectures and people I talk to, and in my development of the business plan of the Urbanek device and protocol, I get to go to many meetings, business meetings, journals, professional meetings. And when I'm talking to a female, often they say, well, what do you do? And I say, well, I developed a non-surgical treatment for TMD. Literally half the women say, well, I've got those symptoms, or I've got that problem. I know I have that. I have TMJ. I've been told I have TMJ. It's a very huge problem. So it's debatable what kind of number you want to put on it, but I can tell you that you're not going to run out of patients who have one or more of those symptoms that are still untreated successfully because they still have the symptoms. So lots of patients to see. So that's why you want to build a practice in this, because you actually can solve the problem and serve all those patients successfully, make them happy, get rid of their symptoms and problem for them, which is the reason I hope that you went and did all the work and the studies to become a doctor. And so in my mind, that's the reason you do it. Secondarily, it's a great practice builder, because once you successfully treat those patients and they've had pain for 5 years, 10 years, 30 years, 40 years, and you make their symptoms go away, they bring all their children to you and their grandma, and they bring in all the friends that they have to visit the doctor who solved their problem that nobody else could solve. You're their hero. We see it around here all the time. So it's a practice builder. It brings in more income. It brings in more patients. Whether you want to do this full-time, like my practice is, or you want to just add that service to your own current practice, that's up to you. I think that it's a stretch to think that many of you would want to devote your entire career to just treating one problem, TMD, but it's a doable deal. So I always teach with props, and I pulled this up several times before. I'm not asking you to read it, but over the past 10 years, this is our progress on numbers of patients, numbers of patients served, numbers of devices delivered per year over the past 10 years. After I established the success of what I uncovered, and then started doing the proper marketing which we'll explain in detail. That's important to how to build a practice and why you have to use that marketing, which is not a dirty word, and how you can do this. I had a discussion with a very prominent dental businessman in the dental industry. I showed him this, and he said, "Oh, that's a hockey stick. That's what we always like to see in developing a business." But that is certainly possible in any market, in any city throughout the United States and Canada and beyond, at least in the civilized, developed world, to perform that kind of increase in your service if you know how to get the word out to the public and the right public to get it to. So, so building a TMD practice, you want to make it simple for the patient. You want to make it simple for yourself. You need to know how to market it and not get all tied up in complicated things. We talked about my experience with the National Academies of Sciences, Engineering, and Medicine, and the consensus report, which was established going on now almost 4 years ago, when this consensus study and group was brought together of some of the finest people in sciences in the United States of America at that time, and brought to Washington, D.C. to discuss temporomandibular joint disorders. And at that meeting, which I attended the entire meeting, I did a presentation describing why inflammation within the temporomandibular joint was discovered and causing all of those symptoms, which I mentioned. And I just wanted to bring out that since that time, this is a very complicated document. I'd recommend it if you really want to get really complicated in the arena of temporomandibular joint. You can read this. But after I did my presentation 4 years ago, and I made it really clear that the sciences needed to look into inflammation causing all those symptoms directly, which I can explain. I have not been contacted. I've not been questioned. I have not been criticized about my knowledge and my statement that I'm trying to make clear to those that are interested in treating temporomandibular joint. And pretty much they want to make it complicated in the greatest number of ways they can. But if you're going to be successful in building a practice, you can't make it complicated.
I come to you this afternoon after a long day, which is very enlightening, as a patient advocate, a researcher, and a provider. Thank you for allowing me the opportunity to address the committee. My purpose is to direct the committee to an area of investigation that I have found productive. My name is Anthony Urbanek. I received my dental degree and master's degree in anatomy and cell biology from Indiana University and my medical degree from Vanderbilt while working toward a PhD in anatomy cell biology. In 1976, I was awarded a 2-year fellowship from the NIDCR, then known as the NIDR, for my self-directed study to induce reproducible temporomandibular joint craniofacial anomalies in an animal model by way of laser-induced intrauterine fetal surgery. After completing this study in my internship and residency in oral and maxillofacial surgery at Vanderbilt, I have spent the last 40 years in private practice in Nashville, having performed over 2,000 surgical procedures on the temporomandibular joint, half as open procedures and half as arthroscopic procedures with varying degrees of success and failure. I believe I am well qualified to comment on the current research, treatment modalities, and provider training for the amelioration of the symptoms of TMD. 10 years ago, after applying all my surgical skills and knowledge to the conundrum of TMD, and because of the less than predictable results, I decided that I could not in good conscience recommend surgery as the solution for the enigma. I had a burgeoning practice of patients, mostly females, showing up at my door requesting help, but I would now have to turn them away. Because of my broad background in the sciences and independent research, I decided instead to create my own study and ignore the myriad of congresses, textbooks, lectures, articles, and recommendations of colleagues from the many disciplines involved with the TMJ. I decided to instead apply the guiding light of my career. If one cannot find a solution to a problem, he is either asking the wrong questions or asking the wrong people, or both. So began a study by collecting data from the actual source with a very simple process. I began sitting with my patients and asking them and encouraging them to tell me everything they could about their symptoms, their history, and their problem with TMD. Many of them, at least half of the cohort, which was 12 out of 24, many of them repeated a similar comment. If I place a pencil eraser, my tongue, my finger between my front teeth and gently bite down, it feels better. After hearing this multiple times, the light bulb ignited, and I thought, I wonder what will happen if I make a device that fits between the front teeth and that it can be worn for 24/7. I constructed such a device and gave it to one of these patients who had symptoms for 20 years, asking her to keep it in her mouth 24/7, taking it out only to eat, and return in 3 weeks. 3 weeks later, much to my surprise, she said her symptoms were all gone. Then I applied this strategy to another patient and another and another. Not everyone had 100% of their symptoms subside after 3 weeks. But everyone had substantial improvement and continued to improve over time to the point of wearing the device limited to nighttime only. After treating 30 or 40 patients in this manner, I knew the anterior occlusion, disoccluding the posterior teeth, was effective, but I had no idea how it worked. None. What were the anatomic, physiologic, pathologic, neurologic mechanisms at play that allowed a simple device that only occluded the anterior teeth and disoccluded the posterior teeth to have such a profound effect on relieving the symptoms of TMD in patients who had suffered symptoms for 10, 20, or 30 years? The next step consisted of what Albert Einstein euphemistically called thought experiments. For sake of brevity, I only have 5 minutes. I will give you the factual findings in bullet form. 1, every TMJ patient I operated on had inflammation as the consistent common denominator in the first line of the pathology report of the mandatory tissue sample. In other words, the common denominator of all TMJ problems in my practice was inflammation. 2, 90% of the loads on the temporomandibular joint are from the posterior teeth. This fact has been validated by many, many dental studies. 3, and the centerpiece of my remarks and the understanding of the conundrum and the route to a most viable solution is this. Inflammation within the temporomandibular joint stimulates an autonomic response from the central nervous system to contract first the muscles of mastication, then the muscles of the neck, then the muscles of the shoulder girdle to hold the TMJ immobile in contradistinction to the constant mobility of the joint in normal function and bruxism. This mechanism, well known to our colleagues in the orthopedic literature, explains muscle trismus in tennis elbow, but is conspicuously absent from the dental literature relevant to trismus of the muscles of mastication in TMD. Conclusion. Unloading the temporomandibular joint in a defined manner to offset the continued and unavoidable loading of this joint will predictably alleviate inflammation within the joint and associated symptoms of TMD. Using this protocol, I have successfully treated over 2,000 patients in the past 6 years who continue to report amelioration of symptoms using the devices prescribed. Therefore, I respectfully recommend to this committee focus on evidence-based research and methods for unloading the temporomandibular joint while maintaining normal daily function as a superior way to treat symptoms of the TMD.
All right. So whether or not you have any, first of all, you have to have an interest in the problem. And you have to have, I would suggest you really have an interest in helping people. And it's going to be, if you really have an interest in helping people, you're going to love this, because the patients at times are going to, want to hug you and thank you and shake your hand. And the husbands are going to want to shake your hand and stuff you don't get to see very often, at least in the general dental field or the oral surgery field or the orthodontic field, where you have somebody, we have it happen, break down into tears because they're so grateful that you were able to solve their problem and make these series of symptoms go away. How often in your career as a dentist, as an oral surgeon, as an orthodontist, have you had that happen? It happens around here all the time. So that's a motivation to build this kind of practice. This is a motivation, the patients and the income, that's a motivation. But the motivation to actually have that kind of experience on a routine basis, it certainly motivated me. All right, so here's the mechanism, here's the method. First of all, you need a small number of TMD patients to start practicing on, to use the method, to use the device and protocol so that the inflammation decreases and the symptoms go away. Now, a couple ways to do that. The simplest way to do that is to just ask your current patients if they have a history of any of those symptoms, and your hygienist can do it. Your hygienist can do it on a routine basis, which what I suggest. I did an episode about that, having the hygienist be a practicing partner in developing her skills or his skills, so that bring the attention of your patients, your current patients, that their headaches, earaches, jaw pain, neck pain, etc., if they're suffering from those, can be made to diminish by just asking the question about the symptoms and then doing this simple exercise, pressing on the temporomandibular joint from the open and closed position. And if it hurts, the joint's inflamed. If the joint's inflamed, your diagnosis is made. If they have symptoms, you made the diagnosis right there. No x-rays, no MRI, CT scans. Simple, right? So you can start out just your own patients, or you can do that by routinely asking on your initial examination for a new patient, do they have any of these symptoms? Doing this. If it's positive and they have those symptoms or some of those symptoms, they have TMD. Now, whether or not that particular patient wants those symptoms to diminish, whether they're bad enough or significant enough in that patient's life where they think they need help, that's up to the patient. Just ask them. If those are significant and you want help with that, we have the solution. If you don't want help with that, fine. If you don't have symptoms, you don't have the problem. The other way to start getting a small, and I do mean you don't need many to start with, small line of temporomandibular joint patients, is to just send out brochures. Now, in our company, TMJ Services, we actually do the major marketing steps for our doctors, our clients, our network providers. And we start by customizing one of our brochures, just a 3-panel brochure, which is then mailed out to potential referral sources within the geographic area of that doctor. And basically, it's these are the symptoms. This is how you diagnose the symptoms. You don't need fancy x-rays. And we have the service in our office to fix this problem, TMD. And those brochures will go to walk-in clinics. They'll go to PCPs, ENTs, your colleague general dentists, oral surgeons, chiropractors, physical therapists, basically medical people, practices within your community who know little to none about TMD. They just call it TMJ. Everybody knows TMJ. A little education in the brochure. And then sooner or later, one of those brochures is going to land on somebody's desk and they say, yeah, I have this problem, or I know my wife has this problem, my daughter has this problem, I have a patient that has this problem, and I'm going to try it out. I'm going to send them to Dr. Jones. And so one way or another, you get a small trickle of TMD patients to treat. This is the key, and I've explained this many times, but this is how you build a huge TMD practice. When those patients start coming through your office, whether they be 1 a month, 2 a month, 3 a month, and I call that a very small number of TMD patients when you consider 45% of females have the symptoms. A list is created at the time of registration from that patient of all the doctors that they have seen. We call it the doctor list for any reason, not only the symptoms that they are complaining about, but their PCP or their chiropractor or their past ENT doctor, their current ENT doctor, their current dentist, their past dentist, whatever doctors, but especially doctors that they have seen for those current symptoms they're complaining about, for sure, but any doctors on their doctor list that they have seen. Now, that list may consist of 2 doctors, a physician and a dentist, or it can have as many as 15 or 20. We've had several patients fill out a list of 15 to 20 doctors. In those cases, they've been actually documented doctors, practitioners of one kind or another that they've been to try to solve their symptoms that they're coming in for, that they already know. They think they have TMJ problems, TMD. Very important. That list is critical in building a practice. Once that list is finished, then the patient goes through the consultation. If the patient agrees to go through treatment, then the device will be impressions will be made, the device will be made, and the patient rescheduled for delivery of the device. And here's the key, and let me explain this in words rather than written words and verbal. Every time that patient comes back, including the consultation visit, so every contact with the patient that doctor will see, let's say a theoretical doctor who hasn't treated any TMG patients before, but now he has a little trickle coming in because he instructed his hygienist or himself how to uncover a few patients with TMD, or he signs on to our company and we do the marketing for him and drive in a few patients using brochure technique. Then every time that patient is seen, including the brochures, and then when they come back at a check appointment, which is the protocol, at 3 weeks after delivery, then another check at 8 weeks after delivery, then another check at 4 months after delivery, and then usually a final check at 6 months after delivery. When they come back for every one of those check appointments, a letter is generated by our company, not the doctor, which states your patient, which goes to all those doctors on the doctor list. Your patient, Molly Jones, was in our office today with her current symptoms and complaints of ringing, fullness, dizziness, headache, and earache. And by her subjective statement, says a certain percentage of those symptoms are gone. The average number that we hear, we average it all out here in all our patients, the average number we hear at around 3 weeks is 70% of the symptoms are gone. There are certainly patients below 70% at 3 weeks. There are certainly patients above 70% at 3 weeks. But we know, because we keep track of our metrics and statistics carefully, that the average person will come back at 3 weeks and say 70% of the symptoms are diminished or gone. those letters, which go out consistently to every doctor on that patient's doctor list, at every time they see the temporomandibular joint physician, doctor, dentist, those letters go out, and that really impresses upon that other potential referral source that they saw they had a patient. This is your patient you've seen for one reason or another, and most often for the symptoms she came in to see us about, she actually has TMD. And that at any point in time, at 3 weeks, at 8 weeks, at 4 months, at 6 months, she says what percentage of those symptoms are diminished or gone. As I've quoted many times, by the time we get out to 4 months, it's pretty much we can't bring the patients back, because as far as they're concerned, they're fixed. They may not be at 100%, they may not be at 90%, but whatever percentage is, when they feel they are happy and they're satisfied with the results, we can't get them back in the office. We can beg them, call them, email them, text them, please come back. We want you in the record. We want to find out exactly how you're doing. We cannot get them back. Wish we could fill out records, but we have enough that do follow the protocol. We rarely get anybody out to 6 months, rarely. But that marketing technique, that marketing program, starting at the consultation, the letter goes out at the consultation to all those doctors on the doctor list, which says your patient Molly Jones was in today for a consultation regarding her symptoms, listing out the symptoms, and she is in the process of having a Urbanek device and protocol as treatment, and we'll keep you advised as to how she gets along. And those letters go out routinely, and that builds a practice. Sooner or later, one or more of those doctors are going to have the cognition that there is a solution and that they know where the solution is. And that is precisely how that happened. We now have in this practice, and I've quoted this statistic many times, it's getting higher every time I quote it because I keep track, but as of November the 15th, 2022, we have 761 current referral physician, dentist, chiropractor, walk-in clinic, nurse practitioner, referral sources. Those are sources, 761. The reason I know that number is we're getting ready to send out our Christmas cards and our usual Christmas gift, which is a gift certificate to my son's restaurant. My son owns a very nice little restaurant, sports bar here in Brentwood, Tennessee, very successful. And to help him be more successful, I send out gift certificates to all my referral sources, 761 in Middle Tennessee. That is unheard of. I am not bragging. It mystifies me. I know how it happened. I know exactly how it happened. But it happened. And, as an oral surgeon, if I got 2 new referral sources per year, that was building my practice. We average 10 a month, 120 a year, average. Some months are lower than others. We average 10 a month. A couple months ago, we had 18 referral sources, new referral sources in 1 month, using that mechanism. Going to doctors, I didn't know them. I had no idea, no relationship prior, but who saw that their prior patient had these symptoms and that we could help them. And the next patient they came in with similar symptoms, or they thought was temporomandibular joint, or they made the diagnosis by doing this and listing symptoms. And they said, I think you have jaw joint problems. You need to go see Dr. Urbanek or Dr. Urbina at this address, TMJ Services. I think they can help you. So very practical advice. Building a TMD practice. That's how you build it. Now, whether or not you want 761 new referral sources or a list of referral sources, increasing at 10 a month, I don't know. Maybe that's too much for you. Maybe you just want to increase your service to the patient, and you want to add just another $100,000 or $200,000 to your income per year in a very easy way, and you only want to see, 5 of these patients a week, and that would do it. If you saw 5 patients a week, you'd definitely add more than that to your income and all the patients you'd be able to help. And you'd have a substantial practice in your neighborhood, in your geographic area. You'd be the expert in short order. And you do it simply, without a whole lot of extra x-rays and medications and testing modules, which are absolutely totally unnecessary. And that is why what comes from this, it's not a bad document, it's just making it way too complicated because they just refuse to actually study the cause. I've read this book over thoroughly, and just the word inflammation is only mentioned just a few times, and no emphasis on really about studying how inflammation within the temporomandibular joint causes all those symptoms. That is not addressed in this document, which is Priorities for Research and Care of the National Academy of Sciences, Engineering, and Medicine Consensus Study Report on Temporomandibular Joint Disorders of March 2019. And since then, I haven't heard any word about this at all. And I did a presentation and gave them exactly what they needed to know based on, at that time, our current successfully treated 3,000 patients. So it is not complicated. If you would like to investigate how this can be used in your practice, I encourage you to do so. If you want to do it in a simple way and you want to really help people, you'll really enjoy it. I certainly have. My associate has. The other doctors in the network certainly have. We're expanding rapidly. So you can find out more from our website, www.tmjservices.net. You can actually take a peek at our practice at www.drurbanek.com. I can be contacted at Tony@tmjservices.net. Our Director of Marketing Education can be contacted at Naomi@tmjservices.net. So for anyone who would actually like to expand their practice, expand their service, part-time or full-time, great for doctors who are looking to exit their daily activity. They're slowing down. They're looking for something to do that isn't as demanding physically, because it's not physically demanding at all. So for those thinking about retiring, this is an excellent opportunity. We have several doctors in the network that they're in the process of doing that. There are many entry points that you can use, whether you be an independent doctor or a doctor within the dental service organization. I invite those also. We do have a lot of patients to treat throughout the United States and the world with this problem who have been underserved, not treated, misdiagnosed, misdirected. That is a fact. And that is why I make these episodes to stimulate your thinking process, to stimulate you to get involved. So for today, I am Tony Urbanek. I look forward to the next time I will be able to present to you, which will be in 1 week. And this is TMD Demystified.